Good morning. Hi, Dr. Carla Sharp. Uh, uh, it's a pleasure to introduce Dr. Carla Sharp. And for those who were here hoping to learn about mentalism, I'm so sorry to disappoint you. You're in the wrong place. But this ground round is about mentalizing, which does allow you to read minds, but not in the way of the so-called mentalist. Instead, mentalizing is probably a developmental achievement, a skill to understand and interpret our own and others' thoughts, feelings, intentions, mental states, a concept that is fundamental to personality functioning and to psychopathology. Personally, I met Dr. Sharp while working as a child psychiatrist at the Menninger Clinic, and I truly enjoy working, and I think it was more like 10 years or so. She set up an entire research lab in our adolescent unit, and that provided me a first-hand opportunity to see how research is conducted in this area. And I also had the privilege of working alongside her team and consultants, applying research findings in real time to improve the patient care. This collaboration also fostered lasting professional relationships with research assistants, many of whom are now established clinicians and researchers. Rather than telling you the extensive CV of Dr. Sharp, I will just highlight achievements here. Dr. Sharp is the John and Rebecca Morse Professor of Clinical Psychology at the University of Houston, where she also serves as Associate Dean for Faculty and Research. She directs the Adolescent Diagnosis, Assessment, Prevention, and Treatment, called ADAPT Clinic, in the Developmental Psychopathology Lab. Her work has been instrumental in advancing our understanding of personality pathology across the lifespan, particularly in exploring mentalizing as cause, correlate, and mechanism of change. Dr. Sharp has published over 350 peer-reviewed articles, 50 book chapters, and 8 books. Her research has been continuously funded by the NIH for over a decade. Among her numerous accolades, she received the 2016 Mid-Career Award from the North American Society for the Study of Personality Disorders, and in 2018, Award for Achievement in the field of severe personality disorders from the Personality Disorders Institute and Borderline Personality Disorder Center in New York. She's recognized as one of the top 2% of scientists worldwide, and serves as an editor or co-editor for multiple journals. Additionally, she has contributed to the American Psychiatric Association work group for updating clinical guidelines for borderline personality disorders and evaluating nosological changes for personality disorders. Despite her extensive research contribution, she remains actively engaged in clinical work. Today, Dr. Sharp will be presenting on mentalizing, its role in personality functioning and psychopathology. Given my experience working with her, I have no doubt that her insights will challenge us today, provoke thoughtful discussion, and deepen our understanding of mentalizing and applications in clinical work. Please join me in welcoming Dr. Carla Sharp.
Thank you so much, Segundo. I am going to send a request to replace that slide. There we go. Thank you. It's lovely to be presenting today with you. My cat is here. I just see him rising up from my lap. I would have preferred to be there in person today, but I really appreciate the flexibility today, and I'm glad that I get to speak about this topic that I've been working on for the last 20 years, mentalizing and personality pathology. I'm going to just swap my presenter view. There we go. So we're off to the races. So I'm going to start with just a reiteration of the learning objectives, understand the role of mentalizing across psychopathologies and treatment modalities. So what I'll be presenting is mentalizing as a common factor. and I'll be making the case for common factors a little bit. I'm going to also talk about the role of mentalizing in personality development and personality disorder. So yes, common factor across psychopathologies and treatment modalities, but also common factor in personality development and personality disorder more broadly. And then very briefly, we only have 45 minutes. I'm going to just hope that I give you a little bit of a skill, a basic skill in applying mentalizing in psychotherapy, so that you've got something that you can go do differently already this afternoon when you see patients. So let's just define mentalizing first. Segundo did a really nice job already saying that this is a basic human capacity that we are born with. In fact, some animals are also born with rudimentary capacity. And it really comes down to the capacity to reflect on your own mind and the mind of other people in order to make sense of yourself and to make sense of other people and your relationships. So it is a very important capacity. It is something that helps us be with other people and have rewarding relationships with other people. It also enables us to understand ourselves, and we'll be talking a little bit about its role also in personality development, in self-development as we go along. So mentalizing has really, there's a nice graph that Peter Fonagy sometimes show the increase in mentalizing studies over the years. But there's a lot of books that you can go and look at that really summarize the work on mentalization-based treatment for personality disorders across a broad range of other disorders, mentalizing in clinical practice, mentalizing in mental health care, mental health practice. And this is the most recent version summarizing all of the work that's been done in mentalizing treatment thus far. My own challenge in mentalizing comes out of a desire to really distill the core components of mentalizing. So I'm going to show you a book that I published just a couple of years ago with Dick and Bevington. A quick note, though, that mentalizing has also been now recognized. MBT, mentalization-based therapy, has been recognized as one of the evidence-based treatments for personality disorder. This was the Christia review that was done a few years ago. This one is the one for BPD that came out just a couple of years ago. And then there's also been a meta-analytic review for adolescents. So yes, we've seen all of these handbooks for mentalizing being published, as well as these systematic meta-analytic reviews that has solidified it as one of the evidence-based treatments for BPD alongside dialectical behavior therapy. However, as I said, my interest, and it was born out of the fact that I have a CBT background. So I struggled to understand MBT in the beginning and wanted to find ways of communicating the basics of MBT to people like me, people who come out of a CBT background, people who tend to do more directive kind of skills-based therapies. And so a couple of years ago, Dick and Bevington and I took it upon ourselves to try and distill the basic building blocks of mentalizing. And we wrote this book, Mentalizing in Psychotherapy. And one of the important messages that we tried to communicate in this book was that mentalizing can be used in any form of psychotherapy, as a CBT therapist, as a DBT therapist, as a schema therapist. No matter what type of therapy you do, your therapy will be better if you are conducting that therapy in a mentalizing stance. And so this was the main message of this book. So really, whether you're doing MBT, whether you're doing DBT, whether you're doing CBT for personality disorders, whether you're doing schema-focused therapy, whether you're doing TFP, any good psychotherapist will be in a mentalizing stance. Why is that? It is because, and I'm going to show you pictures of all kinds of interactions, whether we are interacting with a friend, whether we are interacting with a child, whether we're interacting with our partner, whether kids interact with each other, whether we interact with older kids, whether we are interacting in the therapeutic context. All of these interactions rely on this one very basic mechanism, which is called mentalizing. So really what mentalizing is, it's a common factor that cuts across all of our interactions and a skill that we are working on every day to improve on. This is the basic building block of mentalizing or interactions. We are in a constant serve and return. You can call it also a dance with other human beings. This is the central happening of our therapy as well. We are constantly in a serve and return. And mentalizing is what keeps the rally going. If we are mentalizing our client, if we are mentalizing our children, if we are mentalizing our colleagues, our partners, we are keeping the rally going, and we are building in understanding, a mutual understanding of each other as we go along in this process. So why are common factors important? So this is just backtracking a little bit before I get to the meat of the argument for today. Just why is the field transitioning to common factors? And this is something that you may have noticed in psychotherapy research, that we're beginning to move away from the sort of circumscribed manual-based approach to understanding psychotherapy and understanding psychopathology. So a lot of the things I will be saying right now was discussed in this paper that was focused on adolescents with personality disorder, but really is relevant for the whole of the field of psychotherapy. So just all of us are aware, if you are of a certain age, that we experienced a CBT revolution in the 1960s and 70s in response to real concerns about the iatrogenic effects of psychoanalysis. By 2012, 45% of therapists were doing CBT, 18% were doing psychodynamic therapy, 22% eclectic, and 14% humanist. So CBT revolution, was very important, took the field by storm, and many of us got our training in this sort of period of the CBT revolution. The second big thing that happened around the same time is that we moved away from prototypical descriptions of psychopathology to very symptom-based phenomenological descriptions of psychopathology. Some people have talked about also the splitting that took place in an attempt to get more specific about what a disorder is. And we moved between DSM-1 from 128 disorders to DSM-5, 541 disorders organized according to 22 diagnostic categories. We did all this as a generation, I'm part of that generation, despite the well-known problems with the idea of categorically distinct disorders. We know there's high heterogeneity within disorders. So one person with two people with the same disorder may look very different from each other. We know there's high comorbidity between disorders, calling into question whether we are really looking at the separate disorders or perhaps there's some commonalities between disorders. There's a lot of within-person variability over time. So we've learned that people don't have a disorder and stay disordered in a categorical sense. There's a lot of ebb and flow of the disorder. We've really struggled with a lack of specificity in external validators for disorders. So we'll have two disorders that both have emotion dysregulation as a key correlate. Lack of retest reliability for most disorders and lack of inter-rater reliability as well. However, because we were boxing disorders into categories, we then started to do manualized treatment for each of these categories. So we would have an anxiety workbook, we had a depression workbook, a PTSD workbook, and so forth. And we lay down these criteria for when there is an evidence base for a particular disorder. So at least 2 RCTs showing superiority compared to a control condition. It has to have this very well-defined population, people with inclusion criteria strictly met for this disorder. And then we would use this treatment manual that was designed specifically for this disorder. So these were the 3 things that that happened. Now, when people like Bruce or Peter started analyzing the effects of this, we discovered that we have a lot of treatment protocols. So in this study that he did already now more than 10 years ago, 750 treatment protocols for addressing child and adolescent problems. 192 evidence-based treatments for youth were described by SAMHSA. And when we delve into that evidence, they are mostly conducted in lab settings, which is not real-world settings. They mostly conducted with non-referred youth, because in these RCTs, you put out an ad and you really just try and get kids into the sample that has anxiety or kids into the sample that has depression. Only 2.1 are clinically referred in these trials that we have based our evidence base on, which means that these are not the same kids that get referred to our real life clinics. When we actually look at usual care and compare these specialized manualized based treatment to usual care, the effect size drops to 0.30, which is quite low if you think about that. That's lower than cancer treatment, for instance. Probability of 0.58, if we think chance is 50, that a youth is randomly selected would do better in the EBT than in usual care. So really the take-home message was that we could just be doing what we're doing in our usual clinics. These evidence-based treatment that we've spent so much money on over so many years are not that much better than usual care. So we came to the conclusion that EBTs do not outperform usual care among referred more severe youth, the youth that we actually treat in our clinics. So what are the lessons that we learned from this? Number one, that psychiatric disorders are not categorical entities, but rather dimensional constructs. What do we mean with that? We mean that symptoms lie on a continuum. This was the classic Haslam study where he looked into which disorders actually meet the criteria for categories, and only 14.7% of disorders have met those thresholds for being a category. The second lesson that we've learned is that patients move in and out of clinical threshold, and that we had to become better at treating underlying causes of the disorder than the symptom itself. I was just reviewing another paper yesterday for BPD outcomes, and like usual, the outcome that is studied is borderline symptoms. This is not actually how the psychopathology works in time. We are much better positioned to look at underlying causes of the psychopathology than at the symptom level. We've also learned that patients below clinical threshold are as much at risk as someone who meets the diagnostic threshold. This was a study done in psychological medicine by Lee et al. In 2018 that showed this. So really, treating the category when a person moves over clinical threshold leaves out a lot of people who are suffering in exactly the same ways as those who are above clinical threshold. This is just another study that showed it the same point for depression. And importantly, if you've kept up with nosological debates in the literature, we've learned that there are broader dimensions of psychopathology that explain the covariance among psychopathology symptoms that we find in the DSM. So here at the bottom are all of our old traditional categories, and what the HiTOP consortium started showing us is that all of this can really be organized according to fewer dimensions that explain the covariation among all of these symptoms. We've also learned that personality disorder, like all the other disorders, is not a category, but is better understood as a unidimensional severity continuum. So I'm just going to illustrate this by referring to sort of 3 cases that we wrote up in a Lancet review seminar for this. I mean, you'll see this case 1 is a youth, a female, the breakup with a boyfriend, inpatient, mixed internalizing, externalizing picture. Case 2 is middle-aged, female. The therapist is retiring, which is the precipitating factor. She's outpatient, more internalizing picture, a sort of quiet sea of desperation that characterizes her course. And case 3, a 36-year-old male, he's out of work. He's coming in because he had a domestic violence incident with his wife. It's a mandatory evaluation, a more externalizing picture. And his course is this sort of anger oscillating with guilt and despair. So this is really just to illustrate that heterogeneity within disorder, that all 3 people met criteria for BPD, but they really look very different from each other. Yet we use the same criteria to try and diagnose, and we've got a polythetic approach. So we say, okay, if you've got 5 of these symptoms, then you meet criteria for BPD. That means that there are 256 ways of meeting criteria for BPD, which again calls into question the categorical nature of this disorder. Here are the other 10 disorders that we still find in section 2 of our DSM, the main section of the DSM-5. Borderline being one of those 10 categorically defined personality disorders. Now, importantly, when we look at this, we know, like I said, there's heterogeneity, there's comorbidity with PDs and with other common mental disorders. And the end result is that clinicians most often diagnose PD NOS because no real person fits neatly into the PD box. It doesn't, like the other disorders, also acknowledge the ebb and flow, the within-person change, and it puts this emphasis on dispositional traits. It's stigmatizing rather than what the personality does, personality functioning. We've also shown in a study in 2015 in the old Journal of Abnormal Psych that when you try and factor analyze the symptoms of all the PDs, here are 6 PDs, the items cross-load onto each other's factors. So you don't get all of the avoidant PD symptoms loading onto an avoidant PD factor, the borderline symptoms onto a borderline factor. In fact, the best model for understanding how personality disorder work looks like this. All of the disorders load onto a general personality disorder severity continuum. And then you can look at specific factors that characterize some of the flavor of this maladaptive self and interpersonal functioning, which is the general factor of personality disorder. So we started thinking about personality disorder in the same way that we think about IQ, that we all lie on a sort of personality quotient, IQ, an intelligence quotient of some sort, but that we can then differ on the flavors of how this basic intelligence expresses itself in individuals. This is indeed what the work group for the DSM-5 suggested when they came up with the alternative model for personality disorder, or short AMPD, the alternative model for personality disorder. And if I were in the room with you today, I'd ask you to put up your hands and say how familiar you are with the AMPD. I can actually see you, so I may ask if you can just put up your hand if you are very familiar with the AMPD. I'm going to try and see. I don't see a lot of hands going up. So I am assuming that you are mostly working within section 2, the 10 categories of personality disorder. So what is this new, better conceptualization of personality disorder? What is that general factor of personality disorder as characterized in the AMPD? So we call it criterion A, or level of personality functioning, and you will find it in section 3 of your AMPD. And Segundo said earlier that I've been on a work group to assess the evidence of the AMPD from the last 10 years since the DSM-5 was published and the AMPD was published in 2013, to see if we can move it back into section 2. There'll be a paper coming out in World Psychiatry. We just got it accepted yesterday that gives you all of the evidence now according to the APA guidelines for acceptance of personality disorder into section 2. So watch out for that. Here's the description of LPF and criterion B, criterion A and criterion B. So when the clinician assesses a patient, they assess self and interpersonal functioning, because what research has shown is that what BPD, narcissism, antisocial, avoidant, OCPD all have in common, all of those 10 categories have in common maladaptive self and interpersonal functioning. That's the core distinguishing features of personality disorder Yes, people with depression have interpersonal problems, they have self problems, but that's not the source of the disorder. The source of the disorder in depression is mood. The source of the disorder in personality disorder is self and interpersonal functioning. And then you get mood problems later because of that basic deficit or basic impairment in self and interpersonal functioning. So as a clinician, we evaluate identity, self-direction, empathy, and intimacy. Empathy and intimacy are the interpersonal components. Identity and self-direction are the self components. And then you can go over and assess criterion B. When you assess criterion A, you assess it over 5 levels: healthy personality functioning. I can hold on to myself in interpersonal interactions. I've got a sense of identity. I get on with people. I'm self-directed. And then we go up 1, 2, 3, 4. 4 is then very severe, where people have lost all sense of identity, self-direction, when they really struggle to take the perspective of someone else, when they have real problem in fostering and maintaining rewarding relationships. So once I've decided where my patient lies on this 5 level of personality functioning, I can then say, how does this maladaptive self and interpersonal functioning expresses itself in this person? Is it more of a negative affectivity, neurotic flavor? Is it more of a detached flavor? Is it more of an antagonistic flavor or a disinhibited flavor? So you can see the old categories reflected in these 5 maladaptive trait domains, but just better organized according to the 5 trait domains that in factor and analytic studies fit the data better than the 10 categories. Now, in the alternative model, there was a third step. You can then go and map your criterion A onto the old categories. In all the reviews that we've published, others have published in the last 10 years, we have really made the argument that this is redundant, because everything that you need to know about a borderline patient is already covered in criterion A and criterion B. Now, why did the American Psychiatric Association ask us to do a review of the last 10 years and make a proposal for inclusion of the AMPD in section 2? Because the ICD-11 has moved to this new system. And so I'm curious to see if the APA will continue to use the old 10 categories when the rest of the world is using criterion A and criterion B. They did retain just borderline pattern as a specifier to give settings like DBT settings a chance to still use their old framing of BPD while they transition to the new system. So this is the ICD-11 has followed suit. Many reviews have been published. Josh Miller and I did a 10-year retrospective of all of the data in 2022. So it's a nice special issue in PDTRT if you want to go look at that. I did a specific review in Annual Review of Clinical Psychology in 2021. And then in 2024, we published another special issue on head-to-head comparisons of section 2. So for instance, BPD versus the AMPD, showing that on all clinical outcomes, the AMPD outperforms section 2. So it does give us, it covers the section 2 categories perfectly, but it gives us a little bit more precision in meaning what we say and saying what we mean when we talk about personality disorder. All right, so this is just a summary of all of the validity and reliability of criterion A. So I'm going to ask you to just trust me on that for now so that I can move on. I want to get to the developmental aspects. So what we are doing when we are transitioning to the AMPD is we say that the treatment should target the common core of the psychopathology, the maladaptive self and interpersonal functioning. Last lesson that we've learned is that for common factors is that psychotherapy, the success we have in psychotherapy is actually mostly accounted for by common factors. So it's the therapeutic alliance, it's the relationship with the patient that accounts for about 30% of the treatment outcomes. This is a huge effect size compared to everything else that we measure that accounts for the treatment outcome. So therapist factors, about 5 to 9% of the variance in treatment outcomes explained by therapist factors, would compared to other factors constitute the largest proportion of the explained variance. Therapist factors seem to explain more variance than the variability between treatments, whether we're doing CBT or DBT or MBT. Evidence-based treatment versus placebo, which is only 0 to 4%, and then the alliance itself. When we ignore the effect of the individual therapy, we erroneously attribute its effectiveness or the lack thereof to the specific treatment. The average recovery rate for more effective therapies is 2 times less than effective for those that aren't effective. And what are these factors? What are the factors that are the common factors? It's self-doubt, it's humility, and modesty in the therapy. And really, if you think back to those trained in Rogerian therapy, it's all of those sort of relational components: empathy, warmth, positive regard, clear and positive communication, and the ability to handle criticism. All right. Last lesson that we've learned from psychotherapy research is that it's actually the factors outside of the therapy room that explain the largest proportion of variance in psychotherapy outcome. 86% of the variance in outcomes has nothing to do with us as therapists. It's got to do with what's happening outside of the therapy room. Only 14% of the outcomes are covered by us, what happens in the therapy room. What are those factors? It's work, it's love, and other factors in the environment. So all of this together says that we need psychotherapy that treats common factors, the relational components across psychopathology, the relational components in personality pathology, and the relational components across therapies. And finally, we need to concentrate, as John Gunderson used to say, on getting a life and activating the natural salutogenic effects of social support and relationships, because that's how we're going to get that other 86% that explains variance in outcomes. We're going to get it going by activating relational components outside of the therapy room. So we're really looking at common factors that help us with relationships inside the therapy room and relationships outside of therapy room. So I'm going to walk you through why mentalizing could be this missing ingredient. So this is a slide that just explains the mechanism of change in MBT. Ostensive cues are what you do when you, and this is your skills that I'm trying to impart in a very short amount of time today. When you are sharing transparently with the client what is on your mind, you're putting your mind on the table, you are sending a signal to the client that what I'm about to tell you is important. The intention for communicating information, you're communicating that my mind is different from yours. You are also communicating that this is what's in my mind, it's different from what's in your mind, but both have an equally important perspective on what we're talking about. It signals a gap in understanding, and it creates a collaborative learning opportunity for you and your client. So when you are doing that, when you're sending those ostensive cues, what you're doing is you're opening what Peter Fonagy calls the epistemic highway, the learning highway. You are telling your client that they can learn from you. It increases knowledge in epistemic trust, knowledge that what the therapist has to offer is in the client's best interest. So the capacity to identify knowledge conveyed by others is personally relevant and generalizable to other contexts, the feelings of being understood, and that the knowledge that the therapist is sending is worth knowing. This practice that happens inside the therapy room then creates an openness to learning outside of the therapy room, enhanced social learning outside of the therapy room. Now the social context can be activated, it can be generalized to other contexts, and feedback from enriched social connections can come back to the patient. And this is then what brings therapy change. And so we've argued that it doesn't matter which therapy you're doing, if you are using these mentalizing components, you're sending ostensive cues, you're opening the trust, this will make all therapy, this is the mechanism of change for all good therapy. This is how people learn from us. Now, how does this translate to young people? I'm going to just map the AMPD now onto what happens with children in their personality functioning as they grow up. So we know that babies come into the world with temperament. research has shown us that temperament maps onto our basic traits, which map onto our maladaptive traits. So these are the continuous aspects of our personalities. However, we know from developmental research that when we think about traits, they are not enough to explain fully our personality functioning. So this is Dan McAdams's model of personality development, and he's developed it out of about 20 to 30 years of developmental research in basic research in child development. Yes, we come into the world with dispositional traits, but this is only one part of the picture of our personality functioning. When we get to about 5 or 8 years of age, we start to have goals and values. We know that we like swimming better than soccer. We know that we've got blue eyes. We know that we want to be good, not bad. And this is an additional layer of personality functioning, the self as agent, that lies on top of this dispositional traits. Importantly, when we get to adolescence, the self as author begins to emerge. And this is where mentalizing capacity becomes really, really important, because now I've gotten to know myself in terms of my traits. I finally have the reflective metacognitive capacity to begin to integrate who I am from a trait perspective with my goals and values, building the story of who I am and who I want to be. And so mentalizing becomes really, really important as young people go into adolescence. They, for the first time, have the capacity for abstract reflective thinking, and now they have to do this work. So traits in and of itself is not enough to explain our personality functioning. We have to include goals and values, our reflective capacity, and mentalizing is the glue that puts that all together. So here's a healthy young person that has an ongoing awareness of unique self and boundaries, a consistent self-regulated positive self-esteem, and can tolerate emotions. A young person that has self-directedness or beginning to have self-directedness, standards of moral behavior, can reflect on self and others, can see the perspective of other people, and then as a result can have strong relationships. So that is an LPF, a level of personality functioning of score of 0. As people start moving up, their self and interpersonal functioning become more disordered, and we have to do interventions to really scaffold that personality functioning early on so that they can be spared all of the problems of personality disorder later on. So just to summarize this piece, humans contribute to an active and continuous process of reflection and interpretation of themselves and others. The capacity for reflective process onsets in adult form in adolescence and then begin to facilitate consolidation of identity and adult role function, love and work. If disrupted, we have personality dysfunction, criterion A. So criterion A really explains the onset of personality disorder. Criterion B tells us about these continuous temperamental traits that are already present from early on, but doesn't really help us to define personality disorder. So I have a lot of empirical studies. Segundo let you know early on, I'm a researcher first, and I'm just going to zoom through them so that we have a little bit of time for discussion at the end. But we've used a longitudinal data set to show that, yes, maladaptive traits do relate to later LPF functioning, self-functioning, if we prospectively follow up young people. So this is just supporting the model. We've shown that self-function, identity diffusion, is a good tracker of personality dysfunction over time. This is also a longitudinal data set in over 2,000 kids. We've also shown that maladaptive identity increments general functioning in predicting personality pathology. And this is important because when we talk about that severity continuum of personality disorder, we're not talking about the old GAF score. We're not talking about general functioning. We are talking about an intrapsychic function, maladaptive self and interpersonal functioning, making sense of self and others, and not just general functioning. This is a confusion that emerged after the publication of the AMPD. It's also not psychiatric severity. So it's not the P factor. if you've followed nosological debates, you know about the psychopathology factor, the P factor, general psychiatric severity. When we talk about maladaptive self and interpersonal functioning, we are not talking about the P factor. We are talking about an intrapsychic function. We've shown that narrative identity, that last level of McAdams's model, associates with personality dysfunction in adolescence, and also with attachment security and mentalizing. And I'll show you why that's important, the attachment security part of it. And that we are really talking about agency, this narrative identity, this reflective function that develops in adolescence gives young people agency. And that's where their self-directedness are going to come from in order to propel themselves forward. We've done a lot of work on measures to measure abnormal or dysfunctional personality functioning in adolescence. The ADA is one of them, as well as the LOPF, the Levels of Personality Functioning Questionnaire. And any of these papers I can send you if you're interested in measuring any of this, as well as a self-report measure of narrative identity. We've also shown that identity diffusion increases personality pathology, so self-components are key for criterion A function, and increases suicide severity. And then with a nice data set that Jess Peters used, she used the CLIPS study, the MIDAS study, and our Menninger sample, and showed the centrality of identity function across age groups for personality functioning. So all of this just to say that the self is really the nexus of our personality functioning, which is a departure from our old view that traits only a personality, and that we are really just going to focus on traits in our personality disorder treatment. So we're moving away from the idea that we are just going to try and regulate emotions. We are trying to say, let's look at self-function as a broader concept. I said I will explain to you why we are interested in this capacity developmentally. It comes from Peter Fonagy's work. This is his model. He talks about the dispositions, the temperamental traits that we come into the world with, but that then through mentalizing, usually the mentalizing of the parent first, later on mentalizing of society, mentalizing of friends, we get feedback on ourselves, and we move from a dispositional self, a trait-based self, in Dan McAdams's word, the self as actor, to a psychological self, a representational self. So it is really mentalizing right through, mentalizing from others, but also our own capacity to reflect on the self that sustains our personality functioning. More research to support these models. We've shown in many studies that attachment provides that early context for mentalizing capacity to emerge. And in several studies, we've shown that mentalizing is then an important correlate of maladaptive personality functioning, and in a recent meta-analysis, all psychopathology. So really coming back to this idea that as therapists, we want to support mentalizing to sustain and to scaffold personality functioning across psychopathologies. Even if you have depression, anxiety, PTSD, you still have a personality. And mentalizing is going to be the engine, the central engine that is going to drive your personality functioning. So in terms of clinical implications then, we must assess personality functioning over and above internalizing and externalizing pathology, whether we are treating personality disorder or not, because we may want to be supporting personality functioning below clinical threshold as well. I'm the mother of 2 kids, and I am very aware and intentional about supporting their personality functioning and their development of self as a mom through trying my best to be a mentalizing mom. Criterion A is conditional to the diagnosis of personality disorder. Criterion B is optional and can be helpful to give flavor to that personality dysfunction. Assessing self-function is essential. It's the construction of a healthy sense of self that we want to scaffold. And when we assess a family and a young person, we want to know, is this person being scaffolded? Assessing family function is essential. What is the mentalizing capacity of the family? Can they slow down? Can they come to a mutual sense of understanding in the family context? And assessment of mentalizing capacity is essential. For interventions, if you want to scaffold personality functioning, you have to scaffold self and interpersonal functioning. DBT was always designed to do this. I think we got sidetracked with DBT a little bit to focus just on emotion regulation. We need to move back to Linehan's dialectic of self and other. Mentalization-based therapy is designed to support mentalizing, of course. And then generalist approaches, John Gunderson's approach for supporting interpersonal hypersensitivity is also very well geared to supporting mentalizing in psychotherapy. So that is it from me. I know it was a marathon, and I hope everybody was able to keep up with moving from psychotherapy research through the AMPD and personality disorder to understanding the downward extension of that for youth. So I hope I got all of this communicated to you in the time that I had, and I'm very glad to take any questions.
Is this one on? Oh, it is. Okay. Did somebody just woot from back here? You did? Fantastic. I love that. So thank you so much, Dr. Sharp. I'm just going to look around the room to see who may have questions. Do you want me to give you my microphone? I'm mentalizing you right now. I'm going to give you my microphone.
Hi, that was a really wonderful presentation. I'm a big fan of the high top model and the AMPD in general, and there seems to be this huge gap between how we appreciate it as researchers and how it's actually implemented in the clinical world. I mean, I know a lot of private practice clinicians who I think probably have never heard of these models in this way, and yet they are so central and needed for clinical practice. How do you think we can bridge that dissemination gap?
Oh, such a great question. Thank you so much. And I think that is the next frontier. I think now with 10 years of research behind us, and I think a comfort with the fact that that these alternative ways, dimensional ways, are probably here to stay. I think the real work, the important work of dissemination and translation into the clinical setting has to begin. Some people are doing that already. I think much more can be done. We have transitioned in my clinic to a pure AMPD approach. And I can tell you that I have families, parents, who get very emotional when we start using the AMPD language to describe what is going on with their young person, because for the first time, a formulation makes sense for them. When we talk about identity development, self-development, when we talk about what they can do to support their child's identity and self-development, what they can do to slow down in the family environment, for them, this makes so much more sense than saying your child has BPD and we need to get your child into DBT. So I think this translation is underway. A lot more needs to be done. There are books coming out. There's actually just a book that was published very recently, Chris Hopwood, Bob Kruger, Bo Bach. That is the clinical application of the AMPD. So watch out for that. It's published public right now. I know that there are other books underway that is trying to do just that. Bo Bach has published an Oxford University Press book. It should come out in a couple of months for the ICD-11. You can take anything on the ICD-11 and just apply to the AMPD. And I think it will really help when the AMPD is in section 2, because then the people who are really at the front line will start using it and help us with the translation. I don't know that the researchers are always the best people to do that translation, but the clinicians know how to do this. And I think getting that collaboration tighter for the AMPD will help us a great deal. But you're asking the exact right question. Thank you for asking that.
Thank you so much. I do have a question online, and it goes back to the common factors. It can be quite humbling that 86% of the variance is explained by nothing that has anything to do with us. So thank you for that reminder. But the question is, any suggestions for how best to engage that 86% that happens outside of treatment?
So if I had more time, I would have put another model on a slide for you, where it's just visually depicted that we can begin to use the common factors. And I'm going to speak about mentalizing, but if you're a DBT therapist, think a little bit about your DBT or your CBT as well, to really become more intentional about how we translate what we do in the therapy room to outside of the therapy room. How we've done that for mentalization-based therapy is to really, we use MBT and the MBT interventions in the serve and return, in the here and now with the client in the therapy room. But then we begin to say, okay, so what are we learning here that we can apply outside of the therapy room, and become very intentional about that, and articulate it. Put your mind on the table. Say that you're not that important. Say that what you and I do here is important, but how are we going to get your mom to understand that? I work mostly with teens, and I love saying to teens, okay, how are we going to help your mom understand you better? How can you talk to your mom so that she can actually hear you? Because I can hear that you are saying she does not hear you. She does not understand you. So let the two of us work together to see how we can get mom to hear you. So it is becoming a little bit more intentional, not assuming that what you're doing in the therapy room is being generalized outside of the therapy room, but becoming very intentional. Share it with the client that that's your agenda, that what happens here has very little effect. We need to take what happens here and bring it outside. How can we do that? So I think it is humbling to think about that. And then I think also we've shifted a little bit, at least in MBT, to become a little bit more case managers than what we've ever been in the past, where we would be more intentional about setting up an environment that can have salutogenic effects. So, we used to leave that for the social worker, or we leave that for the occupational therapist, but becoming a little bit more intentional about how we can also set up the environment. A good example for teens with personality disorder: don't take them out of school, keep them in school. There was a time that we took them all out of school, put them into therapeutic boarding schools, put them in inpatient settings. We are very clear that the data is very clear. Don't do that. Keep them in school and start thinking about how can we change school to, and how importantly, how can we get the teen to express their needs and what they need from school more in a better way.
Thank you. Just going to take a scan back to see what other questions might be here in the audience. And if nobody, I'm going to ask one. You sure nobody has a question? Okay. So my question is about the tension that exists, I think, for many of us in this room between those evidence-based treatments that we know or have been led to believe are going to be efficient and effective in a time-limited manner, because access here is so challenging. So I'm wondering if you can offer some commentary on how applying this sort of way of thinking about mentalization impacts treatment time, and sort of how we should be thinking about it relative to access and demands that we can't keep up with.
Another great question, because I think this is one of the other lessons we've learned, is that everybody, and I'll use personality disorder, but it'll stand for depression or for any other disorder too. Everybody with personality disorder does not need the same dosage of treatment that the trial used. So the trial, again, would have included people who met clinical threshold, They were on the severe end, and our trial shows that 12 months of DBT or MBT works and what is needed. What we've learned is that because psychopathology lies on a dimension, much smaller dosage of this can work. So that's the first thing I would say, is begin to use the treatments. Don't refer out just because you can't do 12 months of DBT or CBT. Or MBT. I think that's what we used to do. We would say, okay, I'm going to refer out because I'm not set up to do this, the evidence-based treatment. So loosening those boundaries of what you can and can't do a little bit, because we know that people do respond to lower dosage treatments. And then I think the other thing is, and this is really thanks to John Gunderson, Lois Joy Kane, who and Paul Links, who developed generalist approaches. Coming back to the idea that anybody can treat someone with personality disorder. I invite you all to read some of the GPM books. It's published by the American Psychiatric Association. There's one for adults, there's one for adolescents, and it gives frontline clinicians the tools to manage personality disorder in their clinics without having to learn DBT and MBT, the evidence-based treatments. So I think both within the specialized treatments to loosen the rules a little bit and say, I can be in a mentalizing stance without doing 12 months of mentalization-based treatment. So, and then in general practice, to become a little bit more confident. Now, of course, we have to do this ethically. So I would still recommend get a supervision group together that does peer supervision for GPM. Or get in touch with Lois Joy Kane and see if you can join one of the GPM groups. So we want to do this ethically and responsibly when we loosen the rules and we break out of our confines. What I think is important, though, is that we stop referring on and saying, I can't treat this person because they've got personality disorder, because you can treat people lower down the severity spectrum, and even people above clinical threshold, you can treat with good common sense. So
I feel like nobody should say anything after that particular final point. But with that, I will say thank you so much for a very thought-provoking talk, well backed by a lot of research and your life's work. So thank you so much for being with us, and thank you to all of you.
Thank you.
Dr. Sharp, we're going to give you maybe a 10-minute break or so while we reconfigure ourselves, and then we'll see you back here. You can mute your video or go and come back, whatever you'd like, but it's the same link.
Wonderful. I'll be back 10 past the hour. Thank you.